Hello. Now, let me have the pleasure of inviting Dr. Sujoy Rai in this auditorium. Dr. Sujoy Ghosh in this auditorium. He is a very well-known speaker and a research worker, now professor of endocrinology at SSKM Hospital. And the subject is also very much interesting. Both this osteoporosis and frailty are twin sisters, each help each other and each motivate each other. Now we will hear from him what is the exact relation between these two diseases.
Thank you, respected sir. At the very outset, I would like to thank Dr. Parthojit for having invited me to speak in front of such an august gathering. He's asked me to talk on a bit of a complex topic in the sense, he's asked me to talk about the relationship between osteoporosis with sarcopenia, and then added bits and pieces in terms of frailty and nutrition, including eating disorders. So I shall try my best. I think in the previous two talks, you heard a little bit about sarcopenia today. I think that is one area where we understand that there is a big problem. We have conventionally been talking about excess body fat as being a problem. We now realize that similarly, having less muscle is perhaps an even bigger problem. So if you're looking at metabolic health of any sorts, number one, excess body fat and insulin resistance and its inflammatory state, coupled with low muscle mass and poorer utilization of insulin and its metabolite is again a problem. So conventionally, when we talk about fat mass, we talk about certain anthropometric parameters, like say BMI, waist hip circumference, neck circumference, and things like that. We also talk about body compositions and body fat measurements. Now, when we talk about sarcopenia, we need to know how we define sarcopenia. It is still in a relatively fluid state the way we are defining sarcopenia, and it is standard definition would talk about age-associated loss of skeletal muscle and function. Remember, just like peak bone mass, we all have different peak muscle mass. And our muscle mass perhaps depends even before conception. The maternal nutrition probably is a major determinant of our muscle mass. So if you look at Dr. Yagnik's work, we are the so-called thin fat Indians. So a complex syndrome associated with muscle mass loss alone or in conjunction with increased fat is sarcopenia. And in a very loose terminology in clinical practice, we say you measure the appendicular lean mass with the DEXA or otherwise, the legs and the arm, and that divided by BMI will give you an idea of your muscle mass. And if that is low, you say that that individual is sarcopenic. Like I said, the definitions are still pretty loose. So what is osteosarcopenia? So we've in the previous talks also heard about the relationship between bone, fat cell, and now I'm going to talk about muscles. Because all of these three come from the same origin, that is mesenchymal origin. So a problem in one is often linked with problems in the other two cell lines. So the term osteosarcopenia has recently been proposed to describe the disease state of individuals suffering from both of these conditions, and it results from the same processes as reflected in the bone and mass. This hazardous duet adding the propensity of falls. So you've got weak bones, you've got less muscles or weak muscles, therefore the individual has vulnerability of falls in addition to having weak bones, and therefore probably has bigger problems. And like I said, they are both mesenchymal stem cell origin, a decrease in osteoblastogenic and myoblastogenic potential in favor of adipogenesis has often been observed. So the mesenchymal cells, instead of growing into bone and muscle, shifts towards the fat cell. Deb Mallo was asking about pioglitazone in the previous session. This is probably a switch in the cell lineage of the mesenchymal cell which happens in a lot of us. And there is low-grade inflammation and certain cytokines, alterations in the level of growth factors which all lead to this. And moreover, infiltration of fat into the muscle or the intramuscular adipose tissue leads to muscle dysfunction. Now, this has alterations at the level of mitochondria, And if you're looking at all the pharma companies who are making these anti-obesity drugs, they would refute what Nitin actually said to say, you don't lose 20% or 25% of muscle. Actually, when you are measuring, there is a loss of fat within the muscles, which kind of, if you are evaluating by a DEXA before and after the use of an anti-obesity drug, you feel as if the muscle has also shrunk. It's the fat inside the muscle which has actually changed. I think the story is actually a bit of both. However, what is important is we need more studies to show that alteration of intramuscular fat, does that lead to improved metabolism, improved metabolic activities. So factors which affect both muscle and bone is multiple. Of course, like I said, genetic factors, intrauterine nutritional factors, of course, vitamin D, several growth factors like growth hormone and IGF-1 axis is important. Steroid hormones are important. With age, there will be a natural decline, inflammation, and of course, a lot to do with steroids, obesity, and diabetes. And there seems to be a constant crosstalk between the muscle and the bone. There, as you can see, through endocrine and autocrine pathways, several factors are secreted both by the muscle as well as the bone, which has a positive as well as a negative impact on each other. So you can't do one without the other. So if you're looking at the clinical implications, osteoporosis combined with sarcopenia will have tremendous negative impact, particularly in ambulation. And like I said, people are more likely to fall. And what is interesting, if you see, is that at least 1 in 6 fragility fracture occurs in individuals who got normal BMD in the proximal femur, telling you that there are factors beyond the bone which makes someone vulnerable for a fracture, results in a fall, and ultimately fractures. So factors in addition to bone loss contribute to age-related increase in fractures, risk as fragility fractures increase dramatically with advancing age, but bone mass does not have a comparable decline. So the point that I'm trying to make here is if you look at the trabecular bone score over a period of time with age, you will see that there is a change, there is matrix degradation, but the rate of fracture that goes on increasing is disproportionate to the loss of bone. And this disproportionate increase in fracture risk compared to the alteration in the BMD can partly be explained by the disproportionate loss in muscle mass that happens as we age. So this is a particularly interesting study which again highlights that non-bone factors play, like falls, greater role in fractures, particularly in older adults. So here comes the question and the concept of the dysmobility syndrome. So syndrome that encompasses osteosarcopenia, obesity, and other fracture risks, some of which we understand, some of which we don't, actually lead to greater risk of fracture. And in that, you can see osteoporosis, sarcopenia, diabetes leading to poorer bone quality and obesity. All of that leads to fractures. What about certain evidences? Let us look at a few studies. The osteoporotic fractures in men study followed up close to about 6,000 people for about 6 years, and dysmobility seems to be a major risk factor for osteoporosis-related fractures and hip fractures, and dysmobility was an independent risk factor for fractures even after adjustment of fracs. I think still we are in the state of infancy when we are talking about osteoporosis and osteoporosis-related fractures, as if a simple test like a BMD or even whatever scoring systems we are using, the fracs or modified fracs, they all underestimate the risks of fracs and very poorly explain the actual correlationship with bone densities and fractures. Again, if you look at the enhanced studies, dysmobility was associated with increased mortality risk as well, the hazards ratio of 3. This particular Australian study showed a significantly higher prevalence of falls and fractures in the osteosarcopenia group, quite understandable. So what do you do in terms of interventions in osteosarcopenia? We all talk about physical exercises, very few of us actually do it, has beneficial effect on bone and muscle with additional effects of decreasing BMI and fat infiltration. Exercise decreases falls and fractures, though a combined effect on bone, muscle, and mobility. We all talk about protein supplements, but it's very difficult even with the best exercise and nutrition to increase muscle mass. Vitamin D levels have to be maintained so that levels are optimal. There is some data to suggest that dietary protein and vitamin D helps in better musculoskeletal health in postmenopausal women, and that's what the guidelines talk about. Nitin was talking about certain newer drugs. Now I think just like we are talking about drugs to reduce fat, we will more and more talk about drugs that will maintain muscle mass or will improve muscle mass. We still do not have any approved medication in that particular area, but clinical trials are going on. This is perhaps one of those drugs which is a monoclonal antibody against myostatin and activin receptors 2A and 2B, which is being tested. Particularly the ones who are marketing anti-obesity drugs, they are undertaking at least 6 or 7 different molecules that are undergoing clinical trials. Moving to the second bit of what Parthojit wanted me to talk about was eating disorders and osteoporosis. So we are all aware from traditional teaching that anorexia nervosa is one of those disorders which will increase the risk of fractures during lifetime. And it's almost a threefold increase, and more than 50% of individuals with anorexia nervosa will at least have one fracture during their lifetime. And a lot of this can be explained by the reduction of the bone mineral density itself, and a major proportion of them will either have low bone mass or osteoporosis. Now, observational studies suggest that in these individuals, bone formation markers are decreased and the bone reabsorption markers are elevated. And if we look at what actually leads to this bone loss in anorexia, there are several postulated mechanisms. So there is a hypothalamic hypogonadism, so is a hypo. In that individual, the estrogen levels are likely to be down, and the effects will be worse if the individual develops anorexia nervosa peripubertally, when the bone accuracy is maximal. The bone loss will be relatively less if the onset of anorexia is in adulthood, much later, where at least some amount of bone has been accrued. There are also certain association studies to try and look for the relationship between testosterone and DHEA with relation to peak bone mass. However, it is difficult to tease out the difference between that due to testosterone or is it an effect of lower estrogen activity. Again, leptin seems to have some impact because the body fat content correlates directly with the amount of leptin that's there in the body, and those with anorexia nervosa will be having lower levels. What about other growth factors and hormonal alterations? So if you're looking at, say, someone with, say, protein energy malnutrition, someone with anorexia, you expect that there will be a state of growth hormone insensitivity syndrome. That means baseline GH levels will be higher, but the IGF-1 levels will be lower, and the IGF-1, as we know, has stimulatory effect on osteoblast, and low IGF-1 levels in anorexia may contribute to the low bone density. Cortisol levels, again, in anorexia is altered, and even in any stressful situation, and hypercortisolemia, we are all aware of, has certain negative impact on the bone as well. Oxytocin is another newer hormone of interest which seems to have some effect on the bone as well. So what do we do in such situations? So the first thing would be, irrespective of what happens in the bone, you need to try and correct this eating disorder. So inputs from a clinical psychologist is very important. I recently had one patient of type 1 diabetes with anorexia nervosa, predominantly probably because the family was after the girl, trying to tell her every time you eat, your blood glucose goes up. So we had to convince her. We've put her on a 7-8 Tg pump, and her blood sugars are normal, and her eating disorder is much better because now she knows even if she eats, her blood glucose is not going to go up. So the weight restoration is probably considered the most effective intervention to attenuate or reverse bone loss. There are several such studies. I've just quoted a box of the studies, and if you look at, there are 3 or 4 meta-analyses of all the studies, some showing, taking into account different kinds of results of studies, but overall it would seem that if the individual has better feeding and has regain of weight, the bone health improves. Again, estradiol replacement is useful, particularly if these are very pubertal. You might actually want to give estradiol for a short period of time. Treatment with DHEA, because I told you, people thought that DHEA deficiency can cause worsening of bone health. Isolated studies of DHEA replacement has not led to any improvement, but when given in combination with an oral contraceptive pill, in these two particular studies that I'm quoting, there seems to be some benefit. What about bisphosphonates in anorexia? There are trials with risedronate and alendronate to show that those who took 10 milligram of alendronate actually had significant improvement in BMD. Similarly, with risedronate, there is also data to suggest that there is improvement. Again, very small study, but looking at denosumab for use of 3 years in anorexia, even that led to improvement. And finally, teriparatide has also been tried, which has also shown that there is improvement in bone mineral density in adults with anorexia nervosa. I already told you that anorexia nervosa is a state where you have growth hormone insensitivity syndrome, that is IGF-1 generation is inhibited. And this particular study looking at 60 women with anorexia showed that when you are using it either in monotherapy or in combination with oral contraceptive agents, there was a significant improvement in bone. BMD was unchanged in the other two groups. Now, we know that you need normal vitamin D and vitamin K for normal bone health. This is one study which shows that if you replace this particular vitamin D, there is an improvement and it will attenuate further bone loss in individuals with anorexia. So I think I've bored the audience enough, and I'll finally finish off by summarizing to say that osteosarcopenia and dysmobility are a deadly combination. Poor bone health with poor muscles will lead to increased risk of fall and increased risk of fractures. Protein and vitamin D supplementations are of benefit both for the muscle and the bone. There are now certain monoclonal antibodies which are being tested, which will improve muscle health. We are still a long way to go with regards to that. Please make sure that you correct hypogonadism. Growth hormone resistance, low leptin, and hypercortisolemia are all linked to bone loss in anorexia. Weight regain is probably the most important intervention in these individuals, and we have some amount of data with regards to bisphosphonate, teriparatide, and recombinant IGF-1 in patients with anorexia. I shall finally stop and invite all of you to join in for the Endocrine Society of India conference, which will be held in Kolkata in September. Thank you.
Thank you, Sujoy, for a very comprehensive talk. I have a small question, like, who are the subjects who need to screen in the earlier age group for this deadly osteoporosis and sarcopenia for the prevention so that no untoward effects occur in the very early age group?
Very difficult question to answer, in the sense that I'll give you an example. We have recently published in Clinical Endocrinology a cohort of our first-year MBBS girls from 3 medical colleges. And believe it or not, 43% is the percentage body fat of first-year MBBS girls. And we've even looked at their muscle masses. If you're comparing their body weight with the muscle mass, they are terrible when you're looking at the DEXA. But when you're just physically looking at somebody, you can't make out. Do you know I have 33% body fat? Do I look fat? But by definition, I'm obese. I am sarcopenic. So that's the reality. And the way we evaluate patients in front of us, what are we taught? We are taught, first of all, look at BMI. Second thing, if BMI is normal, look at waist circumference. If waist circumference is normal, you are more or less certain that this person is not going to be obese, right? The entire myth right now is the way we are defining obesity and sarcopenia. If we were actually using body composition studies, I am certain, and I'm saying this with certainty, people sitting in this auditorium, at least 80% will be at least obese or sarcopenic. At least 80% of this audience. So, we should universally think that everybody has a problem. Our challenge and problem is we have smaller body frames. Those of us who are of my age and older, remember what you were like when you were 18. We have all put on weight since then, right? And we might have got into the so-called normal BMI now. Since age 18, whatever we have put on, it's neither water, nor bone, nor gut. All that we've put on is fat. So I think, apparently you would say you go by all of these parameters that we are talking about. And it is very common. You will find women coming into your clinic with very slender arms and legs who have a central obesity. Face is otherwise okay. This is very common. We see every day. And this concept of lean NASH, lean PCO, lean type 2 diabetes is not correct. We are actually looking at body fat and if we are looking at muscle mass.
CT scan is the best tool for seeing the sarcopenia assessment.
We don't need CT scan. See, first of all, if you can look at what I said, if you just clinically examine and see that there is lean arms and legs, that's one way of looking at it. In our institute, we are using DEXA because we are doing clinical studies. Now the in-body analyzer that you have right now is good enough. It will tell you whether you are sarcopenic. And I think these machines will be another tool which will be almost mandatory in your clinic in the next few years.
So, how often do you use hand dynamometers to screen for sarcopenia?
Again, that's one of the tools that is suggested to see, the hand grip and the muscle strength. It's not very standardized in our India. Do you have Indian standardized data? We don't have any Indian standardized data.
But then you have a definition of less than 18 kgs.
I agree with you, but do you have any Indian standardized data? Where is the normative data for India? Yes, please.
I am Dr. Israrul. Sir, one of the important CTDs that we see, in which we see a very significant weight loss in spite of recommended therapy, is systemic sclerosis. So, do you have any paper particularly related to systemic sclerosis? Since what if they are losing like 20% of the weight, like in the initial disease courses of 2 to 3 years, what percent of that is fat or what percent of that is muscle?
I have no idea. I don't know, honestly. I don't know.
So one comment regarding this, I am a physician and I got to see many patients in orthopedic department with neck femur fracture and other comorbid conditions. And what I find is that many of the patients, almost 60 to 70% of the patients are having Parkinsonism, which are bradykinesia predominant, not tremor predominant. And they are often missed. Because neck femur fracture in elderly, 30 days mortality is 9.6% and 1 year mortality is 33%.
30%.
And another thing, beside all other gait freezing and orthostatic hypertension and other loss of balance, everything, patients on levodopa for a long time are associated with hyperhomocystinemia, which itself is an independent marker of osteoporosis. And there is no guideline to recommend whether we should check the homocysteine in patients with long-term levodopa therapy. And this is a very common practice. Thank you, sir.
Thank you, sir.
So, Sujoy, I just wanted to extrapolate. I have enjoyed your talk thoroughly. I just wanted to extrapolate your findings on the sarcopenia. I completely agree with you that we do not have normative data of Indians, and our stature is not the Caucasian stature over whose data we are piggybacking upon to see how our sarcopenic patients are doing. I'd just like to tell you that we are doing, for the last few years, we are looking at the erector spinae muscles as a sarcopenia or not. CT and MRI both can quantitatively tell us about this data, but the problem is the fat infiltration, which you really correctly pointed out within the muscle, is something we cannot understand and factor in for all the calculations, because you cannot have an MRI which can actually tell you the cross-sectional area of the erector spinae against the fact that 1/3 of that would be fat, so it cannot differentiate and cannot take out that. That is a very major problem. And the second problem is that even if it is a lean mass, I'm sure everybody in the audience has seen people who are lean but have extremely good strength. If you look at the hand power of many, a lean person might have a much better grip power than a person who is really fat, who has built up his muscles with bodybuilding and say steroids and all that. So translation, the real major clinical challenge is translation of the muscle mass to the muscle function, which I do not think there is a solution right now.
Point taken, sir.
Okay, last question from Dr. Kaushik Chaudhary.
Shujoy, another masterful and lucid talk. In the world of bone health, the two of our most difficult problems are in young people with osteoporosis and with CKD. And of the young people, premenopausal women with osteoporosis, I think anorexia nervosa patients present a particular challenge. We glibly talk of restoring nutrition, but as you well know, that is often an incredibly difficult thing to achieve. One of the questions I have for you in your practice, which group of patients with anorexia would you give bisphosphonates to? Because you know there is an anxiety, although it's not proven, that bisphosphonates in very young childbearing women can potentially cause problems. So do you reserve your bisphosphonates for any particular cohort?
For older group of people rather than the younger group of
Right.
people.
So, but you know, those who have completed their families, would you give bisphosphonates? Because sometimes we have no choice but to give bisphosphonates.
But I would try to push it back.
Yeah, exactly.
Yes.
So I think the key message is try as much as we can to improve the nutrition, and that automatically will reflect in bone health.
Thank you.
So thanks everybody. We are running short of time, so I conclude this session over here.